Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast. There's a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. First is our asthma content area. It is not known whether adding azithromycin to standard therapy in patients with persistent, uncontrolled asthma helps to induce remission. In this issue, Thomas and colleagues report findings from a secondary analysis of a double-blind placebo-controlled trial that evaluated the safety and efficacy of azithromycin on asthma exacerbations to determine if the addition of azithromycin to standard therapy helped induce remission. 355 participants who completed 12 months of treatment were included in the analysis. A significantly higher portion of those in the azithromycin arm achieved clinical remission, 50.8% versus 38.9%, and complete remission, 23% versus 13.7%. Better asthma-related quality of life at baseline and the absence of oral corticosteroid bursts in the prior year increased the odds of achieving clinical remission. These findings suggest treatment of adults with persistent symptomatic asthma with azithromycin may help achieve clinical remission. Next is our chest infections content area. The epidemiology of nontuberculous mycobacteria infections is not well described. In this issue, Peterson and colleagues report findings from a nationwide retrospective registry-based cohort study in Denmark of 1,146 adults with nontuberculous mycobacterial, designed to determine the incidence and prevalence of NTM and the characteristics of affected patients. 661 of the 1,146 patients had pulmonary NTM, and 50.4% were male. The median age of those with pulmonary NTM was 66, and of extrapulmonary NTM was 57. The yearly incidence and annual prevalence rose during the study period from 0.4 per 100,000 to 1.3 and 0.4 to 3.5 respectively for pulmonary NTM, and 0.3 to 0.6 and 0.3 to 1.0 for extrapulmonary NTM. The incidence was highest in those who are older than 70, and those with extrapulmonary NTM were more likely to be employed and had a higher educational level. These findings highlight an increasing prevalence of NTM and identified distinct groups with pulmonary and extrapulmonary NTM. Completing this section is an original research article that explored the effect of corticosteroids on long-term humoral and memory T-cell responses of hospitalized COVID-19 patients. On to our COPD content area. The impact of the transition from race-specific to race-neutral equations on the severity classification of patients with COPD when using percent predicted versus Z-score thresholds, which is recommended, is not clear. In this issue, Brems and colleagues report findings from a retrospective cohort study of over 13,000 patients from the Johns Hopkins Health System designed to answer this question. More Black than white patients showed a change in severity classification between approaches when using percent predicted thresholds, 20.2 versus 6.1%, but not with Z-score thresholds, 12.6 versus 12.3%. An increase in severity classification with a race-neutral approach was associated with increased risk of exacerbation when using z-score thresholds, but not when using percent predicted thresholds. A decreased severity classification was associated with lower risk of exacerbation with both thresholds. These results support recent recommendations for use of race-neutral equations in z-score thresholds for spirometry interpretation. Next is our critical care content area. There's little evidence to support replacing manual ventilation with mechanical ventilation during CPR. In this issue, Shin and colleagues report findings from a pilot randomized controlled trial of 60 patients designed to determine if using automatic mechanical ventilation during CPR after out-of-hospital cardiac arrest is both feasible and comparable to manual ventilation. The rate of return of spontaneous circulation did not differ between the groups, 56.7% in the mechanical ventilation group and 43.3% in the manual ventilation group. There were also no significant differences in blood gas measurements, despite significantly lower tidal volume and minute ventilation in the mechanical ventilation group. These results suggest a larger trial is feasible and that mechanical ventilation could be an alternative to manual ventilation post-cardiac arrest. Also in this section is an original research article exploring barriers and facilitators of surrogates providing consent for critically ill patients in clinical trials, and a research letter evaluating emergency department use by patients 3 years after having EVALI. Completing this section is a guideline on the use of intravenous albumin from the International Collaboration for Transfusion Medicine. Onto our diffuse lung disease content area. Little is known of community member experience in views on best practices for running a community advisory board in a rare pulmonary disease. In this issue, Bushweller and colleagues present findings from an evaluation of the process for formation and maintenance of a sarcoidosis community advisory board. Clinician and community members found published guidelines to be an effective tool for structuring formation of a community advisory board. Facilitators included a dedicated coordinator, collaborative development of projects, and a focus on improving clinical care. Obstacles were formal structure, focus on projects with academic merit, but no immediate impact to patients, and over-reliance on digital resources. These findings identify facilitators and impediments to the success of a community advisory board. Completing this section is a How I Do It review on the interdisciplinary diagnosis and management of patients with interstitial lung disease and connective tissue disease. On to our education and clinical practice content area. The diagnostic accuracy of AI-assisted lung ultrasound deployed in real time to diagnose pneumothorax remains unknown. In this issue, Fiedler and colleagues report findings from a prospective AI-assisted diagnostic accuracy study of AI lung ultrasound to recognize the absence of lung sliding in patients with suspected pneumothorax. 241 evaluations were derived from 62 patients. AI lung ultrasound showed a sensitivity of 92%, specificity of 80%, an area under the operating curve of 0.89, and an accuracy of 0.82. These findings suggest real-time AI lung ultrasound has a high sensitivity and moderate specificity to identify the absence of lung sliding. Our pulmonary vascular content area is next. Risk stratification is the cornerstone of the management of pulmonary arterial hypertension. The most accurate model for risk assessment at baseline and follow-up evaluation is not clear. In this issue, Zahe and colleagues evaluate data from consecutively enrolled patients over 11 years in a pulmonary hypertension center to determine if the REVEAL Lite 2 score better discriminates risk than the Compara risk assessment models, both at baseline or on follow-up evaluation. 296 patients were included for baseline and 196 for follow-up evaluation. At baseline, the C-statistic of REVEAL Lite 2 was 0.74 compared with 0.68 for the Compara 4-strata model and 0.63 for the Compara 3-strata model. At follow-up, the C-statistic of REVEAL Lite was 0.74 compared with 0.70 for the Compara 4-strata model and 0.65 for the Compara 3-strata model. These findings support further validation of the models and the potential for future guidelines to include REVEAL Lite 2 in the management algorithm. Completing this section is a special features article, a compendium and review of chest antithrombotic therapy for venous thromboembolism disease guidelines from 2012 through 2021. Next is our thoracic oncology content area. There is no consensus about which patients with pleural effusion should undergo medical thoracoscopy and which should undergo image-guided or assisted needle biopsy as the first procedure to ensure greater diagnostic accuracy. In this issue, Menton Tass and colleagues report findings from a prospective randomized parallel study of 228 patients with undiagnosed exudative pleural effusion, designed to determine which biopsy method is more appropriate for which patient. Stratified by whether pleural thickening was present, each group was randomly assigned to image-assisted pleural biopsy or medical thoracoscopy. The false negative rate was higher for needle biopsy in both groups, 30.3 versus 3.1% and 11.9 versus 4.7% in those without and with pleural thickening, respectively. The rate of complications was 8.5% and 15.8%, respectively. These findings show higher diagnostic success for medical thoracoscopy in all patients with pleural effusion, with a smaller difference in the accuracy in those with pleural thickening. I encourage you to read our Humanities and Chest Medicine section, where you'll find a point-counterpoint article that debates whether it is ethically permissible to use frailty scoring to determine the allocation of medical resources under conditions of scarcity in the medical ICU, and an exhalations article titled Microaggressions, Small Cuts, Slow Burns, as well as our commentary series, where you'll find a piece describing preparing for the new pulmonary critical care medicine and critical care medicine ACGME requirements for critical care ultrasound training, and another titled Neglect of Pleural Fluid Analysis. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all of the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the August issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.